the Kingston CCG governing body meeting in public. I want to welcome everyone, and especially Neil Ferrelly, who is our Director of Finance. So welcome, Neil, and welcome back to the area. So thank you. And just to confirm that this meeting is quorate. Can I just ask members of the board and also members of the public, if you've got mobile phones, if you can just switch them to silent or off, please, for the duration of the meeting. Now, I've just got a script that I need to read out. So, in relation to questions from members of the public, the CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it is not a public meeting. This means that there is no opportunity for the public to ask questions apart from that offered at the chair's discretion. There is a specific slot at the end of the agenda for questions from the public as well. The governing body meeting is also being video recorded as part of the commitment to make information as accessible as possible. The video will be put onto the website within a few days of the meeting, and the CCG does not allow for any other recording of the governing body unless again agreed by the chair prior to the meeting. The CCG has a protocol setting out how it will conduct its meetings, and this is available on the website. So coming up to declarations of interest. Are there any declarations of interest on items on the agenda that the governing body members have not already declared? No? Okay. Thank you. So as regards apologies, we've got Pete Smith.
Dr. Naeem Iqbal.
And Dr. Iqbal.
And Catherine Yates.
And Catherine Yates, who's our nurse member. Okay, so if we can come to the minutes of the 41st meeting, which was held in January. So just as regards accuracy, can we just go page by page? So we've got page 1, page 2, 3, 4, 5, 6, 7, 8, 9, 10 and 11. Okay, so we can sign those off as an accurate record. As regards to the actions that have come out of the last set of minutes, it says that we're going to arrange for nominations to be sought for a lay member to be part of the EPRR, which is the Emergency Preparedness Assurance Process. So have we got that? Tonya?
No, I didn't. Sorry.
Okay, do you know when we'll be able to get that by?
I'll let... No.
Okay, and discussion on the Senate governing body champion to be progressed and the outcome reported to the next meeting. Julia? I thought I saw her. Ah, there.
Naz, I think in the absence of Dr. Pete Smith at the moment, I think you've stepped into that position.
Okay, thank you. So if we can come to questions. Now we've got one question which has been submitted in writing. So is Simon Balfrey here? No? So what I'll do, I'll take the opportunity to read out the question and then just ask one of the governing body members if they could reply to it. So it says, "Dear Sir or Madam, here is my question for you. When will we have the funding necessary to provide long-term mental health care for those who desperately need it? Too many are struggling against PTSD, anxiety, depression, suicide thoughts and more. Kingston I Hope provide an excellent service for those who only need short-term care. Their staff are excellent, highly qualified, caring and compassionate, but the demands on their services puts considerable pressure on them, which is totally unreasonable. We need more funding for mental health care, funding that the government has promised, but is too slow in providing. I know what it's like to struggle against anxiety, depression and PTSD. I've suffered from suicidal thoughts from my childhood onwards. Don't wish to speak for myself, but for everyone else in the borough who needs this support. When will the funding be available, and when will we get the support we need so desperately?" Phil.
It's always heartrending when you hear somebody talking about the struggles that they've had. And obviously we need to take account that it is really tough when you're struggling with mental health challenges. In terms of us as a CCG, we're working very hard to try and improve what we're doing. The IAPT service, the psychological service, is being expanded currently because the access rate has to go up, but they have done very well. They're hitting all of the targets they have to hit in terms of access currently and in terms of recovery. And we are putting extra funding in so that they can increase that access in accordance with all of the national targets over the next year or two. We are also funding an emotionally unstable personality disorder service. There is an interim service going in from the 1st of April to allow us time to reassess that service across the whole of South West London, so people will have access to that. It's worth a word about PTSD, post-traumatic stress disorder. That's a kind of a catch-all for a number of different conditions. Ordinary PTSD, if we can call it ordinary, is certainly within the scope of IAPT to deal with, but where you get complex PTSD, then it does need specialised services, and we have an agreement with South London and Maudsley to spot purchase help for people who particularly need that kind of intervention once they've been assessed. We're also putting additional money wherever we can into mental health services and seeking to enhance them and improve them across the whole of the borough. And we are particularly looking at the crisis care services, and the Trust is looking at how they can improve those, and we are working with them on that. So we are certainly meeting what is called the Mental Health Investment Standard, where we have to put more money into the mental health services, and we are trying to work over and above that wherever we're able to, but obviously money isn't limitless in the current situation in the country. I think that's all that I need to say at the moment.
That'll be great, thank you. And Joe, would we be able to provide a written response back based on Phil's response? Yes, Rob.
Yeah, I'm sorry if it's a stupid question because I have a voice. But is mental health services on e-referral? And do you get the same sort of information on the GP system where GPs can refer people through with particular types of symptoms, etc.? Also, I've seen Liz just walked in. She's probably not aware of what we're talking about. She might have something to say about it because she's in the Surrey comment this week about extra funding. So.
Phil, we'll let you settle down, Liz, and then I'll explain. Okay, Phil.
GPs can refer to appropriate services depending on the condition of the individual. Patients can self-refer to the psychological services, and in fact currently about 70% self-refer, but GPs are equally able to refer to that service. There are a whole variety of other services that GP access depending on the particular condition of the patient.
I've fallen in love with e-referral now. Now we've got all the complications of it all. Do you actually use the e-referral, so it's more sort of
No, e-referral is not used for mental health services, although saying that whenever we do referrals from primary care into mental health services, we provide as much information on the referral form so that mental health services are aware of the patient's background, past medical history, medication, etc. Okay, thank you. Liz, I didn't know whether you'd want to say anything more about mental health funding. Phil responded to a question about mental health funding and about the improvements that we as a CCG are trying to do within mental health.
The question isn't in response to your article in the Surrey Comet, Liz. The question is nothing to do with what you were in the Surrey Comet about. It's a separate question that came to the governing body.
That's okay. All right. Thank you. Are there any other questions pertaining to items on the agenda that we can take now from members of the public? No? Okay, so if I can come to item 1.5. So the items that were taken in private on the 8th of January were to do with Wesley Lodge closure, Mill Place update, the 5% QIP and the PIDs, and the request to convene a collaborative decision-making committee in Common, which was meeting in February. We also reviewed the local Kingston Richmond delivery unit and the senior management structure of it, and also looked at the remuneration committees in Common. And these were approved. These items were approved. If I can come to the Chair's report, I'm just going to give you a brief report verbally based on 3 areas, so London, South West London and local. So at London, we've been meeting as a London Health Partnership with clinical and management leads across London, looking at ways of being able to looking at ways of being able to do provision of once across London to help support the local and the regional delivery of services. The second thing at a London level is that NHS CCG, which is the NHS Clinical Commissioners, held a roundtable event with NHS England looking at the 20% cost reductions and we gave a lot of feedback back to NHS England on how they could support us as a system to be able to help deliver that. At South West London level, a couple of things is that South West London have now appointed a strategic clinical lead for the MSK capability framework. This is to try and help support the single point of triage for MSK services and also for the first contact practitioners. The second thing is around the clinical conference, which we're holding in April, and this is to try and look at the clinical priorities across South West London and come to a combined view across South West London as to what we feel clinically we should be concentrating on to be able to take forward, and this is going to be supported by the clinicians at a South West London level. Locally, we've held governing body sessions and seminars looking at elements of the long-term contract, the GP contract, and also primary care networks, which have just been which were published last month. We've also looked at the outpatient transformation, and that's being refreshed at the moment, and that's a local issue. Ian Thomas is the new Chief Exec of Royal Borough of Kingston, and we are starting to develop the relationships with the new Chief Exec. And Kingston Hospital currently are going through a recruitment process for their Chief Exec, as Anne Radmore is now the Regional Director of East of England. Okay, so that's my elements. I think that if we can come to your report, Sarah. That's it.
Okay, so just a brief update from me. So firstly, I was lucky enough yesterday to go along to meet the Kingston Leadership Group to talk about the future of the place for Kingston, and it was a really positive meeting with Ian Thomas from the local authority, members from the GP Federation, but also people from the CCG and from all the other providers in Kingston. They've got some, which you will know about, some high-level priorities, and are talking about how to take forward the work around integrated care across Kingston, which I thought was a very positive discussion. And we talked about their need for development and also looking at how do we measure some of the outcomes that we're looking to achieve across Kingston. So that was a very positive meeting. I thought I would also just mention some changes in personnel. So firstly, I'm sure you're aware that the new Regional Director for London has now started. So David Sloman started a few weeks ago, and I'm now part of his London Executive Group, which met this morning. We had a very positive meeting with David about how we are going to bring together the regulators across South West London, working with STPs to work in a very different way. So that was a very positive meeting. And just in case, it won't be of any interest, I'm sure, to the public, but just for the members of the governing body, Ian Dalton will be stepping back from NHSI, and there will be one lead for the whole of the NHS, both NHSI and NHSE, which will be Simon Stevens going forward. So there will be one chief executive across the two, which I think was the direction of travel, but that will be happening sort of within a short timescale, I would have thought, now that that announcement's been made.
Great. Thank you, Sarah. So are there any comments or questions on both mine and Sarah's reports from governing body members? No? Okay. Tonya.
Is it working?
Oh, yes.
Oh, I don't have a little lever. That's sorry. Sorry, very confusing. Sorry. Quite a lot of information in my director's report this time, so I won't go through it line by line, but a few things to update the governing body members on. Both Sarah and Nav have talked about moving forward together, the CCGs in South West London, and our discussions around coming together to work across South West London. There have been a number of new developments, both nationally and locally, that mean it's a good time for CCGs in South West London to review the way we work. We've been working together as 6 CCGs for over a year, and we think we can do things better together for the benefit of our patients. The National NHS Long-Term Plan and its emphasis on the new primary care networks, and the indication that NHS England expects the CCGs coming together in each STP area. And we are exploring what functions we would hold across South West London as a single CCG, and the strengthening of local health and care partnerships. It is a journey we're on, and we're really at the beginning of this journey, but what we've agreed with chairs, the first steps on that journey, is that we will begin the conversations with each GP membership with an initial case for change, that the GP membership and CCG staff will be involved in designing the way we work going forward, that we would create a governance oversight committee which will include lay members, and a leadership forum to be created for senior CCG staff. Of course, there will be regular updates to governing body members on the work as we progress. Moving on, in my report, on the 26th of February, Sarah came to the staff offices at Thames House to sign a time to change pledge on behalf of Kingston and Richmond CCGs, and that links really nicely that Kingston has also been selected one of the 8 areas to host a Time to Change hub. So Time to Change is I suppose it's a movement, an approach that demonstrates our commitment to change and how we think and act about mental health, and ensure that colleagues who face these problems feel supported in our workplace. So it's very much focused on staff. We have recruited 13 staff volunteers as mental health champions who will receive dedicated training in the next few months. As I say, in Kingston, we are a Time to Change hub, and the hub will be led by local champions working jointly with Kingston Council as the Time to Change hub host, Iona, and Health Watch Kingston as the Time to Change hub coordinator. So that's really great that the CCG is part of that work, and I'm very pleased that Sarah was able to sign the pledge a couple of weeks ago. Also around staff survey, we have had our staff survey results were published on the 26th of February. We had a really good completion rate this year. I aimed for an 80% return, and I've got 83.7%, which I think is fantastic, one of the highest numbers around. We're currently reviewing the results of that survey with our Ways of Working group, and we'll report back to the governing body in due course around our actions for improvement. And then moving on to the CCG Improvement Assessment Framework, we've had ratings for mental health, dementia, learning disabilities and diabetes. I'm pleased to say that for cancer and maternity, we would rate it outstanding, for mental health and dementia, good. We do know we need to do some more work around learning disabilities and diabetes, and the reasons what we need to do is included in the report. But overall, that's a really good result for Kingston. And also our local providers of cancer care have received their annual assessment, and I'm pleased to report that they have been deemed to be compliant, and that they are under what's known as routine surveillance. That means there's no material issue. So it was really good that we've got 3 providers, Kingston Hospital, Royal Marsden and St George's, providing really good cancer care to our population. And also on the cancer theme, we now have just appointed a Macmillan GP for Kingston and Richmond, and that's Dr. Sinead Moran, who is a GP partner at Sheen Lane Medical Centre. And Dr. Moran will be promoting the priorities of our cancer strategy, particularly around early detection and supports and promoting the support that is available for patients who are living with and beyond cancer. So I welcome Dr. Moran into that role. As I said, it was a long report this month. Just to say that we have signed and approved our Public Sector Equalities Duty Annual Report, and that's available on our website. The link is included on the report. And we've also, I'm moving fastly, sorry, keep up with me, commitment to improving end-of-life care. So GP practices in the borough are now able to display a daffodil mark as a sign of commitment to improving end-of-life care. Very good, another good commitment towards cancer and also end of life. Very pleased that practices have been able to do that. Going on to the connecting your care, health and social care providers are working to improve the way they connect care for patients across South West London. So that means for people registered with a GP in Kingston, connecting your care will be joining up GP and hospital records for 4 South West London hospitals, so that GPs along with doctors and nurses will be able to immediately see important information about their patients through a secure system to help them make more informed decisions about their care. And I think we've talked about that digital improvement in some of our sessions. Connected Kingston, Iona, I've got my little badge on, so Connected Kingston, the social scribing programme for Kingston continues to grow with over 90 champions trained to have strengths-based conversations with members of the public, signposting or referring them to local services and activities in the borough via a website. Training sessions have been held with the GP practice staff across Kingston, and this base continues to grow. Again, we propose to bring back a report to the governing body in due course once we have some more evaluation and the numbers of people using Connected Kingston has increased. Just to note that there is a National Social Prescribing Day on the 14th of March, and there's a variety of public promotional activities being planned for that day. So just a note for the diary. And finally, Winter Champions. I would like to thank CCG staff who have volunteered as Winter Champions this year, engaging with people in their local communities and voluntary groups to share information to help members of the public stay well over the winter. So I think that's quite a lot of work that's been going in the last 2 months. So I hope that's been useful, but I'm happy to take any questions.
Okay, any comments or questions from board members? It's a long report, but a very detailed report. Yes, Liz.
It was just to use the opportunity, since time to change is mentioned in Tanya's report, to just clarify in relation to your question earlier, Rob, that the funding is for training peer supporters, because I think the founder of Time to Change became quite severely mentally ill because he did not feel able to talk about his problems for a long time, and therefore he was determined to try and change the culture so that people find it easier to talk about mental distress. So we were an organic hub, which meant we had access to the training materials, but now we've also been successful in getting the funding as well in Kingston. So it's training up Time to Change champions, so that people feel more able to talk, and hence my reference to people accessing services. It wasn't implying that the Time to Change funding is itself for services. And there is also, within the Time to Change work, working with local firms as well to get them to sign up as employers, Time to Change employers, who are more understanding of managing mental health problems within the workforce.
David.
I just want to go back to one of the items about what sounded like the integration of NHSE and NHSI. Can I assume that, as that has now occurred, which has been anticipated for some time, that integration will also be carried through the regional offices that have been recently established?
So
no, that's already happened. That's the new regional director, so that happened a while back.
For clarification, so the regional director now, in effect, is coordinating all activities across both commissioning and provision.
That's correct.
Thank you.
And he has an executive team which, as STP lead, just to be clear,
Yeah.
I sit on not as the accountable officer, but as the STP lead. So some of us are commissioners and some of us are providers.
I'm delighted to hear that. I think that represents a significant step forward. I hadn't realised that that had already become the case with the regional officers, but that's good news in my view.
So originally, just to be clear, originally the regional offices, when they were allocated new regional directors, were across NHS E&I, but they were reporting into two chief executives. So they had a chief executive that they were reporting into via NHSI and a chief executive for NHSE. Ian Dalton will now be moving away from NHSI, and Simon Stevens will be taking it over both, which means there'll now be nationally only one executive line coming through. There'll still be two chairs.
Great, thank you. Any other comments or questions from board members? No? Rob?
Being long in the tooth, I work for BT, and boy, have I been through organisational changes. What concerns me is that with BT, the changes were done for organisational reasons and for the benefit of management, and not for the customer. And I can tell you now, obviously, you know, BT services like local bridge services and the like. So it worries me a bit about you keep doing an organisational changes, merging. But really, the main criteria should be for the benefit of the patient, not for the organisation. And that should be falling. And even a little way, I'm sorry for open, but the Macmillan doctor, it'd be nice to see a doctor from the Richmond side and a doctor from the Kingston side, two people running, so they could actually get the ideas from each patch and actually work together to actually bring the best idea to the table. But as I say, be wary. I mean, the organisational changes, surely we're here for best service for the patient, and sometimes they don't work.
So I think that's absolutely right. I think that anybody that's working in the NHS or has worked in the NHS for the past 10 years or so would say that actually bringing together commissioning and provider for the benefit of the patient is actually what we should have been doing for some time. And actually, I think we've probably disjointed some of the things that we're now trying to sew back together in a way that makes sense. So what we should be doing is resourcing frontline services and taking out as much transactional management costs as we can, and actually creating a system that works for the benefit of the local population rather than lots of management structures that support lots of different organisations. And that's where we're moving towards, and I think that's really important for the benefit of the local population. I don't know about individual Macmillan doctors. Did you want to? Okay.
So as regards the Macmillan doctors, Graham Lewis is the chair over at Richmond, and myself, we sat down on several occasions looking at clinical lead roles. There are only a few clinicians out there who are interested in doing commissioning pieces anyway. And we felt that what we would like to do is start looking at joining up, particularly cancer services, because actually we've got one trust that serves most of Kingston and half of Richmond, and we'd like to make sure that that piece is coordinated. So when we took the decision to appoint one Macmillan GP across Kingston and Richmond, it was to try and coordinate the services across both Kingston and Richmond so that we could actually have a standardised way of dealing with cancer services when we're talking with our local trust and also our GP colleagues as well. So it was thought through quite well. Okay.
Because one of the really big or best things that happened in the last 2 years is taking primary care away from NHS England and bringing it down to Kingston primary care with the CCG. That's been, from a professional point of view, it's brilliant. You know, so I wouldn't want to see people walking down yet again to
Yeah, okay.
So primary care currently came from NHS England to South West London, so we currently hold that at South West London level. So we will continue, I think, to try and work at scale where it makes sense, but also ensure that there's a really strong local focus where that's made sense. So anything that we've built that we think is the right thing to do, we will want to keep that as locally focused as possible. And with the new guidance around primary care networks, I can actually see that there's a potential for us to be doing even more around primary care and transformation going forwards. And there is money coming into primary care through that route. So there is huge opportunity there to develop primary care over the next sort of year or two.
Yeah. I think I echo your points that actually primary care commissioning has worked very, very well locally here. We've done an awful lot of good changes under the guise of under the leadership as well of our chair, which is Jim. And I think that we don't want to lose that direction of travel and that transformation piece. Okay. Right. Are there any other questions pertaining to the managing director's report? Yes.
Sorry, that's particularly around structured education and access to structured education. And we just need to, we've developed our programme of structured education for people who live or newly diagnosed with diabetes. So it would be all diabetes, type 1 and type 2. So it's about, and some of that is a recording issue that we're capturing all the people who are going through structured education, and some of that will be me showing that everyone who is newly diagnosed has the opportunity to access structured education. Gareth, I don't know, you're our lead, aren't you, for diabetes? Is there anything else you want to say?
No, I think that's it, and I think there is some work going on at a South West London level to improve access to this structured education that maybe people haven't had access to before.
Okay, thank you. Right, unless there are any other questions, can we go to the next item on the agenda, which is on the commissioning and service changes. So, Julia, do you want to take, first of all, Mill Place?
Thank you very much, Chair. So the first paper being presented this afternoon is to follow up on the November paper that was brought to the governing body with regards to the closure of Mill Place, which is a voluntary sector provider site that provides supported living for people with mental health and substance misuse difficulties. It's an 8-bedded accommodation that is provided by Hestia, who are well known in providing this sort of support and care in the community. They are in leased accommodation, and the leaseholder has decided to sell the property, and Hestia were given first opportunity to purchase the property but have declined. So they presented us with the fact that they would therefore be closing this property in July and intending to sell. So before we move forward with this work, we sought the advice of the Kingston Council's Health Overview Panel to see whether they consider this to be a significant change that would require engagement and consultation wider than the residents who were placed in Mill Place. They came back and actually said, because the closure was out with the control of both the CCG and the provider, that therefore they did not feel that we should need to go out to wider consultation. However, they were concerned and needed assurance that we would be working with the 8 of the 6 clients at that stage to ensure that they were suitably, they were assessed and suitable alternative accommodation was provided for them. And equally, at the time when I came to the November part 2, we had not sat down with the clients, and we did that after Christmas because we didn't feel it was appropriate at that time to sit down with them just before Christmas and say, just to let you know, the accommodation that you've been living in for the last 6 to 12 months, which is a short-term provision. It is primarily provides low to medium support for clients who are generally independent with proficient living skills and have their own, take their own medication. And they stay for 6 months to 2 years as part of their step down and as part of their recovery journey. And as part of the process of anyone in any type of supported living is we would, with their care manager, undertake an annual review to see whether or not the care and the placement that they're on is appropriate anyway. So this was all, we do have a managed process. So, as I said, at the time of writing this report in February, we had 6 clients in Mill Place. 3 were in the process of being stepped down anyway as part of the annual review. And there are 3 clients that we're still working with regards to moving them into what is suitable alternative accommodation. There is some existing accommodation within the borough that the council have, and we're looking at that. And again, Hestia and other providers who are known to us actually provide that level of care. So we will not be placing people with providers with whom we've not worked previously unless that's more appropriate. And we're working with the Royal Borough of Kingston care managers, social workers in that process as well. So this is really, report is coming to the governing body to make you formally aware of this service change and give assurance that the process and the progress to date in managing this transfer of these clients to suitable alternative accommodation. As I said, we know from looking at the accommodation we have currently that we do believe there's sufficient capacity within the local area for these people, if it's appropriate, to be placed there in medium to low level support. To date, all of the clients have been working with us, and where it has been appropriate, the families of the clients have also been involved. There have been one or two who did not want their families to be involved in this decision because it was about them and their recovery and where they best felt they ought to be. The other piece to just put in is that the funding associated with these clients in Mill Place is being used to utilise their alternative place. We are working to manage the transfer in line with the timetable required by the landlord to vacate the property. So that's all I wanted to say. I'll take any questions.
Okay, thank you, Julia. Any questions from the governing body? I just got one question. I'm presuming all the residents at Mill Place were Kingston CCG residents?
Yes, they were, yes. They are.
Right. Thank you. Rob.
Right. I understand you talked a lot about the existing patients, etc., but we've been talking about mental health here. Surely that facility is a facility that's needed ongoing. Should we not be looking that you should be provide that facility somewhere in the borough? Although it may be coming out of this place, it's pretty easy to find somewhere now for these people are coming out of this in the near future. But this facility that's going to be needed ongoing, isn't it?
So,
In fact, it could increase, but the way that's going at the moment, the number of people requiring this service probably will increase. So we should be looking at some sort of...
If I can just get Phil to come in and then Julia.
This is a particular client group who have relatively high needs. The majority of people do not need that kind of what is tended to be called slow rehabilitation in the past. And that client group tends to be a diminishing number because there are other ways. We don't have a current waiting list for people who need that kind of accommodation, so it would be not much point at the moment to re-provide that when we don't have people that are ready for it.
the other thing we are doing, we do have across the council and ourselves, we have, I think it's 8 different properties which we have contracts with, as well as supporting individuals in homes and in other places. And one of the things that we are constantly doing is looking at what the need may be. But as Dr. Moore has pointed out, at this moment in time, we don't have a waiting list for people who need this level of support.
Any other comments or questions from board members? So the board is being asked to approve this. So first of all, I'd like to get your views on is the board assured on the process that has happened to reach this point in time? Yeah. And do we approve the direction of travel for closure of Mill Place? Yes, agreed. Okay, thank you, Julia. And now Wesley Lodge.
Another closure. Again in November, as part of the governing body, I brought to your attention the fact that Your Healthcare, who is the current provider of residential accommodation for people with learning disabilities and complex physical disability that's provided and is sited in East Elmbridge in Weston Green, had decided that for a number of reasons, particularly to do with the environment in which this residential accommodation is now, the fact that it is not in a community where the local residents can join into local activities, that they decided that they would seek to close this 8-bedded unit. So they gave notice to us as the host commissioner, and of course, as the paper said, it also affects other commissioners from Richmond and Surrey local authority. We, at the time of being notified of this change, had only one resident in Wesley Lodge, and in fact, again, it goes back to a similar conversation about the placements and the types of accommodation for people with mental health as we had earlier. Actually, in terms of the type of accommodation and the type of need, this was not a facility that actually was now meeting need, and hence we'd been over time, we'd actually only had sort of up to 5-6 residents in there at any one time in the last couple of years. Before we went forward with this closure, we again took advice from the Health Overview Panel Chair with regards to whether or not this was considered to be a significant change, and again would require consultation. And after their consideration, they decided that we did not need to consult on this service closure. And so what we've been doing is, again, we've been working with the residents, or at the Kingston resident, and the other commissioners for the other residents have been working with their respective residents with regards to assessing their needs. And again, this is all part of the annual assessment and review process that we would go to look at the suitability of placements. This is being led by our learning disabilities case manager to actually ensure that we find suitable alternative accommodation for the 4 residents that were in there, but in particular for the single Kingston resident. As I said, the building itself and the model of care that was being provided at Wesley Lodge was really probably not where it is outdated, and therefore actually that led to the decision, as well as challenges with trying to recruit staff to work in that particular environment. So that's what led Your Healthcare, our community provider, to make that decision and take that through their board and formally notify the CCG. So, as I said, we've been working with the residents and their families to undertake an assessment to find the most suitable accommodation for them and to manage that smooth transition for them. We got advice from the Health Overview Panel that there was not a need for consultation, and we continue to engage and support the families and particularly the residents through this process. So again, I'm coming to the governing body to provide an update on this service change and to ask whether or not you are assured that the process and the progress that is being undertaken in managing this service change and the timely transfer of clients to suitable alternative accommodation, you are assured by the process that's being managed by both the CCG and Your Healthcare with these individual residents. To date, there's been no resistance from family or from the individuals concerned. There is one individual who is subject to court protection, and we are taking that through, but the relevant legal requirements, and so we're continuing to work and support the individuals as we effect this transfer. Are there any questions, please?
Thank you, Julia. Any questions for board members? No, Rob. So, sorry, Robert, is that to do with the Oak Hill site, or is that to do with Wesley Lodge, in terms of the divesting of...
We're trying to find alternative locations for these services, right? And it's not done by Your Healthcare.
Yeah.
Well, Your Healthcare are looking to try and take over the Oak Hill surgery for the community bed, but maybe there's a accommodation there.
Sorry.
They're actually looking at the PCSS building, they're not looking at Oak Hill. And I think for me, the fact that we've got an 8-bedded unit with only 4 people in it suggests that that's not an offer that is either attractive or being used by the population. So it's not for want of not wanting to use those beds, it's just not a model that is popular or is the way forward. So we've got an 8-bedded unit that's only got 4 residents in it.
So it makes sense to put it into a bigger location where...
I think we are absolutely committed to providing the right support for individuals.
Okay, are there any questions, any other questions from governing body members? Okay, so the board is asked that are we assured on the process that's been carried out? Yep, we are assured. And are we happy to approve the direction of travel for the closure of Wesley Lodge? Approved. Okay. Thank you. So I think, Julia, this still stays with you. And the CQC send inspection report, please.
So, as you will recall, in September, the Care Quality Commission in Ofsted inspected Kingston's special educational disability needs provision across the council, across the CCG, and with the providers, and in particular Achieving for Children. As a result of that inspection, the CCG assessed that Kingston's SEND provision requires improvement, and a written statement of action was required and is in the process of being pulled together, which is being written by all partners. The written statement of action outlines those actions that are required to address the areas of weakness that were highlighted in the inspection report. And we submitted a finalised draft to both Ofsted and CQC on the 11th of February. And that's attached in the pack for all the detail and identifies the range of actions that we'll be undertaking, both as partners but also us as a CCG with regards to our statutory responsibilities. We're waiting for feedback on the written statement of action. We're expecting that in the next few days, and then on the basis of that we will do a further refresh with the view to having a finalised action plan agreed at least by the end of March. That doesn't mean that we've not been actually working on the actions and resolving some of the issues that were raised as a result of the inspection. If just to recall, as in the background, the areas and the areas of weakness related to the health, education and care plans, the leadership and monitoring by the CCG of the implementation of the 2014 reforms, and also the relationship with between parents and parent representatives in the borough. In January, we advised the governing body that we'd agreed to increase some of the designated medical officer time to support implementation and delivery of the action plan for SEND, but also we have approved funding to recruit to a full-time designated clinical officer post who will really work with the local providers, linking with the Achieving for Children and with council colleagues in terms of turning the weaknesses to strengths and eliminating some of the difficulties that we've had to date. And the CCG also committed to ensuring the commissioning and delivery of high-quality health services for parents, carers, children and young people with special educational needs and disabilities that result in outcomes, improved outcomes and chances for exceeding when necessary, in line with our statutory duties and responsibilities as outlined in the Children and Families Act. So we made that commitment. So since we've last reported to the governing body, and we agreed that this would be a standing agenda item, and that it will then also be considered by taken into the Integrated Governance Committee. As I said, we've increased the clinical hours for the designated medical officer, and also we are recruiting to a designated clinical officer. We're developing a quality assurance framework across partners so that we can have the assurance, the quality assurance of the services that we're providing, and in particular linked to the health, education and support plans, and the Council for Disabled Children are supporting us with that. And we've had the first meeting of the Kingston SEND Partnership, that was chaired by the new Chief Exec of the Royal Borough of Kingston, which myself and Tonya Michaelides as Managing Director both sit on. We have also been contributing to a draft 3-year SEND transformation plan that was developed out of the Send Futures conference that was held last summer, and the development of that has been led by Achieving for Children as the local provider, and that sets out the challenges and the context and elements of the written statement of action and the transformation plan are being brought together. And as I said, we've also been working in collaboration with regards to the joint actions to be undertaken with regards to the written statement of action, and those are listed in terms of how we are going to be improving the poll quality of the EHCPs, how we're going to ensure that leaders are part of the annual review process, that we have the strategic leadership here in the CCG, and that we are building a relationship with local parents. So with regards to next steps, so we've submitted the written statement of action, and we've also started to commence some service improvement activity. So one of the areas that was called out was the early intervention around the 0 to 5-year-olds. So we're co-designing and developing a neurodevelopment pathway for pre and post support for young children, and we're also undertaking a review of a therapies review that was produced to identify how we move forward with that with regards to what the service offer should look like, and be able and discuss that and develop that with parents with regard to therapies and the provision of therapies. And as I say, we are working to re-engage with parents and carers, as well as continuing to engage with children and young people through the existing forums that we have. The other piece of work that we're specifically leading on from the commissioning team is reviewing the Section 75 arrangements which we have with the Royal Borough of Kingston, whereby the commissioning arrangements have been through the borough, and we're now working more jointly on that with regards to oversight of the Achieving for Children services that form part of the health commissioning. So the purpose of today's report is to bring you up to date on the progress with regards to producing the written statement of action. Also the key actions that we have undertaken as a CCG, both as a CCG in our own right, but also with partners with regards to responding to the written statement of action, and giving you some examples of the service development activities that we are undertaking that we believe and will support service improvement. This comes to you for information, but also a request for you to discuss and note progress and respond to the recommendations arising from Ofsted and the CQC Send inspection. I think I'll stop there and take any questions.
Okay, thank you, Julia. There's an awful lot of work that's going into this process behind the scenes from not just the borough, the CCG, Achieving for Children, but also the schools themselves, parents and carers. So there's an awful lot that's going into this very serious paper. I've just got one question before I open it up to the board. When we get the written statement of action back in the next few days, can we just make sure that the Education Commission are involved in some of the feedback in that, if possible? Yes. Okay.
Yes. Do you need, sorry,
so
you're referring to the Education Commission report that's been recently
that's right.
Submitted to the Council? Yes, of course.
That'd be great, thank you. Any comments or questions from board members? Liz?
I noted the Send Partnership Board met on the 13th of February. Will the minutes of the Partnership Board be publicly available?
I will need to check that out, Liz.
No, I think, obviously that's led by the council, so the council own the sort of oversight of that group. I'm looking at Iona might have a view.
I don't know what our standard practice is for internal. It's not an external board, but obviously it's a multi-partnership board, so I'll find out. I think off the top of my head, in terms of the action plan, it definitely will be in public and will be going to various forum, which I think is probably the actions we want to see taken and the progress against those, which I think is probably the most important part of your question, Liz.
Any other comments or questions from board members? No. Rob?
One of the things that RBK have
So I've got a feeling that they're already being contacted through this process to find out what the views are on the patients as well as the carers and the families on this, and I think that there is a review process in place going. The data on the number of families who didn't feel they were appropriate. I think there's an awful lot of detail in the background to this paper as well. So, Julia, I don't know whether you want to add to it.
So, as part of the written statement of action in response to the first significant concern, which was overall poor quality, I am aware that one of the actions is for us to go back to and check out with parents and children and young people that the plans that are now being developed with them, that the process is working for them, but also that the quality of the plans are appropriate. So that is all part of that feedback loop. I'm trying, somewhere in the back of my brain in terms of there's quite a few thousand of these plans. So, sorry? Page 29. Right. Thank you.
If I could just confirm.
Page 29, yes. So there's increased opportunities for parents and carers to participate and give feedback around provision and development of services, but that will also take into account the EHCP assessment process.
They're talking to the people that provide the service. Sometimes it's good to have an independent assessment.
So,
there are other people that they're talking to on the wider scale as well. Iona, did you want to come in?
It was just to confirm that one of the issues when they did the inspection was not all of the EHCPs had been reviewed under the new legislation. There was a very small number. I think it was just 4 were still outstanding. They've all been completed now, but clearly we should have responded quickly to make sure all of the plans had been reviewed. So just to confirm that they have all been reviewed now.
Thank you. Any other comments or questions from board members? No, so this is for noting, and as we said before, this is going to be coming back regularly to the governing body meeting in public, so we'll be getting regular updates, okay? Right, so if we can come to the diagnosis of dementia action plan.
Thank you, Chair. As members of the board will know and members of the audience, one of the challenges for us here in Kingston has been delivering the diagnosis dementia diagnosis standard. In January, we presented to the governing body a deep dive of the activities that we'd been undertaken because we weren't achieving the 66.7% standard. The measure for calculating this standard is based on the rate of people aged 65 and over with a diagnosis of dementia recorded within GP practice systems over the estimated number of people expected to have dementia in the population. And so we've all been aware that this has been a challenging target and we've been working hard to achieve it. I'm pleased to say that actually following the January presentation and when we looked at the data, we'd actually had improved our position by 2.2%. So that is excellent news. And so we're in the right ballpark in terms of working to delivering and achieving this trajectory. However, it's not without its challenges. I think as we explained in the deep dive, we'd looked to what others had been doing. We've been doing case finding. We've had a dementia nurse. We've got a memory assessment service in place. The delivery of the target has remained challenging. So as a result of this, I was sent away to work with my team and with Nerida Burney, who is the lead GP who presented at the last board, to develop an action plan that would enable us to improve further our dementia diagnosis, performance and rate. And so that is shown in Appendix 1. And which I'll refer to. So the main areas of work are very much around continuing to do the active practice-based case finding work. which is working in the practices with the practices through the dementia nurse to actually help them identify and proactively support people who potentially could be at risk of getting dementia, such as those with diabetes, people who smoke, people with history of stroke. People who are housebound and who actually may not be automatically being seen and coming in to being known to services. And there may be a hidden group for people who haven't been in contact with any services or GP services in the last 18 months. We're aware that a number of clients, when invited, or a number of patients, when invited, actually do not follow up when invited for assessment. And there are some clients who have cognitive impairment for whom we would like to do some further follow-up and support them through assessment processes. So one of the key areas is continuing to support practices with active case finding work. We're also going to be doing some very targeted work. We have care homes in the boroughs and residential homes, and we need to work more with those care homes in the identification and assessment of local residents. Your Healthcare, our community provider, provides a lot of care into people's homes. They see about 3,500 patients in the district nursing service alone. And there may be some patients who are living at home for whom there may be cognitive impairment, maybe the early stage of dementia that would benefit from support diagnosis. So we're working with them in terms of getting them to help identify and work with us in supporting people for pre-assessment and in engaging in memory services. We've already been working with, but we'll continue to work with Kingston Hospital around identifying patients at discharge with dementia so they can be followed up by their GP. And also we facilitate a direct referral by hospital consultants into the memory assessment service, so that smooths the pathway. And as we heard last time, we're looking at the review and care of people with Parkinson's disease because there is the potential for them to develop dementia. We're looking at the role of neuropsychologists within the stroke service. We're also wanting to start to engage and work more closely with targeted populations, and we're going to be working with the Community Development Coordinator who works with RBK, who works with various community groups such as the Korean community, but also work with groups such as Refugee Action to see whether we can raise awareness in some of our BME groups who may be being supported by families and may be less aware of the services that are available, the pre-support, and then the ongoing support if there is a diagnosis. We've got the Alzheimer's Society and Stay Well, who are two very active voluntary sector organisations within the borough, and we want to work more closely with them with regards to developing and supporting support services, particularly around pre-dementia assessment and counselling and awareness support. And also they have the skills to work with practitioners and work into practices. We're not always the experts. The other piece of work we're doing is working with the Royal Borough of Kingston in terms of the procurement of our dementia support services, and we expect to have completed that procurement by the end of from June. And one of the things we will be asking them to do is to work and support more with ensuring the case finding, supporting the assessment, working to ensure that people with dementia receive seamless services, and also progress the work for Dementia Friendly Kingston. And then finally, the other work we're doing is continuing to strengthen the ongoing liaison with the Memory Assessment Service as outlined. So based on the existing actions as reported at the last board and these new actions and enhancing these, particularly around the case finding, what we've done as part of next year's operating plan is we have said that we would expect to achieve the standard for 66.7% in terms of dementia diagnosis by the end of Q1 for 1920. I'd like to take any questions.
Yep, Sarah.
So obviously this has been an area that we have struggled with, and I think it's really good to see an action plan now really focused on trying to achieve the target. What I don't see in here is what so if this is all new, I think this is all new is what you're saying, rather than this is stuff we've already been doing, then what's the impact, what's our expectation of what the impact will be of that, and what if we had to invest in order to achieve that? And also, if we have seen a 2.2% increase, what is the thing that we have done in order to make that increase, and therefore should we be doing more of that? So it just feels like a lot of things, yeah. But what I'm not really clear is, you know, I'm sure we should be doing all of them, but you know, what's the thing that's going to actually make the difference? What's our assessment of what the impact will be? And you know, I think we should just get the detail maybe to here.
I think some of the things we have been doing, and I think the existing increase is it takes time for things to work through. The memory assessment process isn't quick. They're referred, there's a wait, they're seen, there's another wait before they have a scan, before we can actually enter that proper coded diagnosis onto the notes. So it takes time for those things to filter through. However, there are quite a number of new things that are happening here, and the approach we've taken is that because we've been working on this for a long time, there is no single silver bullet that is going to solve this. We've got to try and approach this from a whole variety of aspects. And how many are we going to find through this? That's part of the difficulty. We don't actually know how many are out there, and therefore we've got to put all that effort in to see if we can find the people who need that support.
Thank you, Phil. Tonya.
I think I appreciate what has been said, and I think, but I want to echo Sarah's comments. So I'm not quite sure what we've put in the operating plan. Can you remind what we've put in the operating plan for 1920 on achievement? So this action plan has to align to the delivery of that, doesn't it? And that should show a month-on-month improvement of the dementia trajectory. And I know it's very difficult, and I've done this in other target areas, particularly A&E, but you do need to know where to focus your efforts. And if you don't know where to focus your efforts, you end up doing everything and missing the target. So I think we do need some kind of trajectory. We need a link to the operating plan trajectory, because there is an operating plan. I just can't off the top of my head remember what it says, but it will at a point in that year say that we are going to hit the target. We then need to model, I think, this activity against that, and actually see because we have got some timelines within this. So some of the stuff to be done post in the quarter 1 1920, that would have to contribute, because it has to the delivery of that target. So I think we need to see it again with that kind of detail. And I know it's probably not the way we want to do it, but because we are such an outlier in this target now, I understand what everyone's saying around, you know, it's not one bullet, but actually there is not another CCG in South West London who's not making this target. I doubt there are many in London who aren't making this target now. So actually we've got to get a real grip of this. So I think we need to bring it back next time with that trajectory. And actually, I'm still not clear whether this needs extra resourcing or not.
The gap is 35 people, and I have committed in the operating plan trajectories that went in that we would achieve the target by the end of Q1 in 1920. So I would expect us to have landed this by the 1st of July. But take on board the fact that we need to model that through. We have got we have worked out what the additional resourcing is required for this. I didn't put that into this report, because I need to take that through the finance route, but we have made provision to put in additional resource in terms of the dementia nurse and provision for the local enhanced service with primary care.
So I wondered, Naz, if we could have that back at the May meeting, yep, just to see that and see the progress against the trajectory as well.
Yeah, that'd be great. Thank you. Sorry, Phil.
It's not a competition I want to be in, Phil, actually. I don't want to be no, I don't want that's not the competition I want to be in. I want to be the top.
Exactly.
You raised it, Tom.
We are still, yes, but we still haven't made this target. We haven't made this target.
Okay, so with the additional 2.2%, we've managed to overtake a couple. So I'm presuming that in the report that you've got here, January 2018 means 19. Is that right? Yeah.
Yes, sorry, we missed that when we were doing our proofreading. Apologies.
No, that's fine. So yes, can we bring this back in May and have a renewed level that we've achieved or not? Okay, thank you. Right, any other comments or questions for Julia on this report? It's been an ongoing problem for a long period of time. So hopefully, with the action plan that we've got here, it will show some dividends by the time we next see it. Okay. Thank you very much. So this is just for noting. So if we can come to the Integrated Quality Governance Committees in Common report. I know Fergus isn't here, so Phil.
I don't want to go through a huge amount of detail here, but I think to give some of the highlights from this, if that's okay. If we go to page 1 of 17 on your packs, it really gives the highlights there of some of the, what they're called the constitutional standards, and as you will see, it's still the A&E one that is causing us the most difficulty. The target is 95% 4-hour waits, and we're still at just under 92%. If you go down further to page 4 of the actual report, you will see the pie chart, which you've probably become familiar with now, that shows that we are achieving 118, failing 8 and underachieving on 11. That's more green than there were previously, so there is some cautious optimism that there is some improvement. On the next page, you have a list of all of the various targets that we're working on. The top one is the dementia one that we've talked about. Mixed sex accommodation, we've had 2 breaches which are in other areas but still count against us, and those have both been for bed pressure reasons. The healthcare acquired infections are the next 2 reds. We've had 3 cases of MRSA and a number of cases of C. difficile, and those are both being investigated case by case. At present, there's no actions that have been put back on us as a CCG. The next one is the A&E target, which we have mentioned. Ambulance response times are improving quite markedly, as you will see in the associated text if you want to have a look at some of the detail. The following section gives you some narrative in behind the ones that I've highlighted. If you then come down to page 10 and item 1B, it shows our operating plan supporting activity, and the good news there is all of those areas are now green. There are a couple of areas of risk that are in the narrative there, but the anticipation is by the year end we will remain green on all of those, so that is a little bit of good news. The next area is the IAF dashboard, and at the bottom of page 11 you will see the 4 areas where it lists the aspects where we are in the worst quartile nationally. On the next page, it gives you a little bit of text behind each of those. We've mentioned the diabetes, where it's about getting people to attend structured education courses, and there is some work going on that's detailed there. The GP Learning Disability Register, we are trying to increase the numbers that are identified on that, and there is work going on. We've already mentioned the dementia one. People who die with more than 3 emergency admissions in the last 3 months of their lives is being addressed through our end-of-life strategy, and there is work going on in that, and Naz may want to mention some more about that in a moment. The primary care investment standard is a little bit of an artifact and will be corrected when the data is put right. Sustainability, there's nothing, and leadership, the RES standard is something that we are working with Kingston Hospital to improve. So that's just a brief summary of those areas. If you look at the next page, which is page 14, which is our quality premium dashboard. We are still struggling in a number of those areas, and I think by the end of the year we will not see much change on the quality premium dashboard, but that's there for your information. There is then a series of summaries of some of the reports that we've received in the Integrated Governance Assurance Group, and they are there for your information. I'm happy to take any questions if anybody has any. That then goes on to some highlight aspects of performance and quality from South West London, looking across the patch. There's quite a mixed bag of results there. Some are good for Kingston, some we compare badly with, but on the whole, things are looking not too bad. I don't want to go through, there's a huge amount of detail there, and I don't think it's probably necessary to go through the detail here, but I'm happy to take any questions if people have them, or to expand further if people have some particular aspects they want more information on. That was a bit of a gallop through, but I'm very happy to talk further if people wish it.
Great, thank you, Phil. There's an awful lot of data there. So just in a couple of sentences, where do you think our risks lie with regards to this overall report?
Our main, if we talk about risks, I don't think there are huge risks to patient safety or anything of that kind. However, our big risks in terms of our performance are A&E, dementia, the healthcare acquired infections, and I think those are the main areas that we have got to pay some attention to. We're doing well in terms of cancer, not well in early diagnosis of cancer, and that's an area we're working on despite the fact that there's been a huge increase in the 2-week wait referrals. But those are the main areas off the top of my head that I would just point out.
Thank you very much, Phil. Any comments or questions from board members? No? Members of the public? Rob?
Today the NHS have launched the cervical smear campaign, which might bring up all
so, the what?
Smear.
Oh, the cervical smear, yeah, okay. Yeah.
Okay, any other comments or questions? Okay, so this is for information. So if we can come to the finance report, please.
Okay, I suggest we go to slide 5 in the pack, page 126. So these are the main points I just wanted to bring out of the report. Looking at the bullets on the left-hand side first, the CCG still expects to deliver the planned surplus of just over £1 million. We've played in some of the reserves and non-recurrent benefits to use it, have been utilised to deliver that position. Our underlying position now shows a surplus of £600,000. That's the difference between the expenditure we have on a recurrent basis and our recurrent allocation. So we have a small amount of headroom there, and we are still reported to be planning to deliver our full QIP target of 9.8 million. We have underachieved in some areas of the transformational schemes, but we've been able to pick up in other areas. On the right-hand side, I just picked out a few items for this month's report. We're now forecasting an overperformance on the Kingston contract of 4.8 million. That's slightly improved from the previous month. We have now agreed an arrangement with the Trust, so that is our year-end position. The underspend on continuing care has worsened in month 10. We're now showing underspend of 130k. We did have quite a lot of new cases, including 17 fast-track cases. Having said that, though, we've still got quite low growth in the funded nursing care, and that's still forecast to underspend by 238k. The third area, prescribing, we're now forecasting to underspend by 898k. We've factored in the cost of supply issues and offset the Category M arrangements as part of that. And then the final bullet, the primary care delegated budget, we've had a small increase in the forecast. That's mainly because of the global sum pressures. The locum cost pressures that we had at the earlier part of the year have not continued in such a scale, so we've factored in that to the forecast. I did just want to take you on to page 16 of this report. It's 137. So in terms of the risks and mitigations, on the right-hand side of this report, this shows the current areas of overspend in red. So we've got £6.1 million worth of overspending areas, including acute overperformance, primary care and mental health. We've mitigated that largely by the underspending areas that I've described, continuing care, use of the acute reserves, the prior year benefits and the prescribing underspend. You can see we've not factored in any contingency into managing this year's financial pressure at this stage. We have looked at further potential risks that are coming through. There may be more acute overperformance. Having said that, though, we've now agreed a year-end deal with Kingston Hospital. There are potential risks around further continuing care pressures and pressures from children's placements, primary care, LD, and making sure our prescribing position is still as we've reported. And there may be some potential risk around delivery of QIP. Having said that, though, we are holding some more non-recurrent measures which we could play in. We're still holding an element of contract reserves, and to mitigate all of those pressures, we would have to use about 99k of our contingency. So given the forecast, we're still confident about delivering to that position. I think that's all I wanted to just flag.
Thank you, Neil. Any comments or questions from board members? No? Thank you. Members of the public? So thank you very much, Neil. So if we can come to the initial budget for this coming financial year, please.
We are required to set a set of initial budgets at the start of the year, and our next governing body is not until the the first week in May. So we brought this paper so that the governing body can approve a set of initial budgets. We recognise we're still going through a process of agreeing contracts with NHS providers and other parts of the health economy. So this will be subject to some adjustments once we've concluded all of those discussions, but we're asking the governing body to agree a set of budgets before then. Section 1 of this talks about the NHS allocations. We have reviewed this on a couple of occasions, but I think the key things we did want to just highlight are that we've now received 5 years of allocations, which we're now starting to model. And in this financial year, in the coming financial year, there is less reliance on providers receiving sustainability funds, and that's now been built more into the tariff itself. There is a national financial recovery plan which will also help to manage some of the provider legacies as well. There's an expectation that we will have to invest, or we will invest, in the mental health investment standard of 0.7% higher than the growth that we receive. The other main change is that we are adjusting all providers for the market forces factor, and that has a particular impact in London providers, where part of the tariff is adjusted for the cost of the market factors across the country. We have a 5-year transition to adjust the market forces factor, which we're now building in as part of our contract discussions. On that slide, I just wanted to pick out the headline growth rate for South West London is now 5.68. The national average is 5.65, so we're doing slightly better. and we are having to reduce our running cost allowance in the coming year, in the future year by 20% as well. The next slide talks about our systems working. The main area just to flag is we've received across South West London headline growth of 5.68. About 3.9 of that is already passed to Trust directly to cover the tariff. So the only amount we have left to fund growth is about 1.8%. The next slide then has the more detail around our planning assumptions. And you can see from the second column there, Kingston received a growth of 5.19. So it's marginally lower growth for Kingston than the rest of South West London. And then the rest of the table shows our various top-down assumptions we've made about adjusting for tariff, prescribing growth, continuing care growth, the population growth, and inflation for primary care co-commissioning. Now, modelling all of that through, on the next slide, this is just how we've built up our financial plan from the left-hand side, our initial forecast outturn, as we said, our surplus of just over £1 million, taking out the non-recurrent items to the almost central column where we've got our opening plan with our in-year surplus position of 603. And then we've applied those allocation assumptions to the rest of the page. Now, as this is a quite detailed plan, if I take you on to the next slide, which just gives you a diagram of that. So you can see on the left-hand side, we have our forecast surplus. We've adjusted for the non-recurrent items, giving us a closing underlying position of a surplus of 603. The net tariff and inflation costs us 3.2 million. Growth for population and other growth is another 13.1 million. Additional cost pressures is another 3.4 million. And reinstating our reserves is another 2.4 million. Offsetting that, our allocation growth, that 5.1%, is a benefit of 14.1 million. And therefore, in order to get back to the control total, which we've been asked to deliver, which is break even, we need to deliver a QIP target of 7.6 million. So just going back to the previous page, we've modelled, as I say, the various top-down assumptions into this plan. And you can see on the fourth column from the right-hand side, our gross QIP and the QIP investment. Therefore, we're assuming that if we apply all of those QIPs into the plan, the final column on the right-hand side gives us an almost balanced budget of 278 million across those various areas. We still have an unidentified QIP of 1.3 million, which we still need to plan on how we deliver. But we are proposing at this point, where we are in the contracting round, that we agree this summary level of budgets for our initial budgets for this year. Just the final couple of slides to note. In section 6, we've talked about where we are on the contract negotiations, and we are using this plan to share our contract envelopes with our providers. And the next steps are very much to agree the baseline and also identify that residual QIP gap that we've still got unidentified. Happy to take any questions, but I would ask the governing body to approve the budget in line with that final column on the detailed plan.
Okay, thank you very much. An awful lot of data there. Any comments or questions initially for Neil? I've got a couple of questions. Jim.
I just wanted to congratulate Neil on the clarity with which this complexity is presented to us. I think it's excellent. Thanks.
Thank you, Neil. Any other comments or questions? So can I just come to the QUIP piece? It was 7.6 million that has to be identified. So that works out around just around about 3% or just under?
It's just
So the 6.4 that we have identified, are they mainly transactional or transformational?
both. Sorry, a bit of both, Naz, but largely around the outpatient programme and also the work we're doing with Kingston on managing the 15% reduction in non-elective.
So we might need to challenge ourselves a bit more because that's quite a low QUIP for a CCG, and we have got other areas where they have got 5, 6, 7% QUIP to deliver, which will be almost impossible. And if we're working together differently, we might need to think about whether or not that's reasonable based on where we are. I think it's just a question for us to think about going forward.
Yeah, no, understood. I mean, I think that's why we are very much looking for this to agree a set of initial budgets. We're still going through the planning round. We will certainly bring a revision back in May.
Okay, thank you. James.
Yeah, I mean,
Can I just add to that? It's not just commissioners, that's providers as well. So
yeah,
we've got an agreement now across the chief execs across South West London that if we've got a problem in South West London, we will come together to see if we can find the solution within South West London across commissioners and providers, because actually what we want is a sustainable system, because the impact on any part of South West London does have an impact on other parts of South West London, because there's so many cross numbers of patients that go across the system in different ways that actually it doesn't make any sense for us to allow a part of the system to fall over or to not be successful. So that's what we're trying to do together, and I recognise how difficult that is, and it's a very different way of thinking to the one we've had in the past, but we are starting on that road of looking at that and just trying to make sure that that's fair and reasonable. So we're being challenging to everybody in the system, including all of the providers across community, mental health and acute, to make sure that we are looking everywhere to see where we can support working differently.
Okay, any other comments or questions? No? Any comments from the public? Okay, so the board is asked to approve the budget, and it's 278,820 on the lines that have been shown. I think it was on page 150. So are we happy to approve the initial budget for 1920, given the fact that we are going to be looking at the detail as a little bit later? Is that okay? Okay, board's approved. Thank you. Thank you, Neil. Okay, so if we can come to the Council of Members report, Atin.
Thank you, Chair. So since the last governing body report, the Council of Members has met on 2 occasions, in January and February, with good practice representation at each. At the January meeting, Omid Gillenshah provided members with an update on the KMS contract. He advised that the practices will be receiving formal notification of contract variations, and also the new specifications would be coming out. The Council of Members were also asked to consider and nominate members for the KMS design group, with locality representation from each of the CCG areas. We had a detailed presentation from Catherine McDermott, Sue Lear and Jackie Walters on a number of local and national developments. They presented the NHS long-term plan, including details on the financial challenges, new work programmes and the impact on primary care and the upcoming primary care networks. They presented work on the outpatient transformation project and the target to reduce outpatient face-to-face activity by over 30% in the next 5 years. At the February meeting, Omid Gillenshah gave a presentation on the new GP contract with more details on the formation of primary care networks, the requirements and some of the deadlines for this. He also discussed the funding and growing role for additional primary care workforce to be ramped up over the coming 5 years. He also gave details on the new state-backed indemnity scheme for GPs, which is going live from April 19. We welcomed Keith Nurcombe from Dr. Link, which is a software that's been commissioned across South West London. It integrates with our EMIS systems and provides an online triaging platform that patients can access 24/7, and it offers patients advice based on their symptoms and has been shown to help manage primary care workload. We welcomed representatives from See the Signs, which is a software that can be accessed via a smartphone app and also integrated into EMIS. It's for clinicians to use to help as a clinical decision-making tool for patients who present with symptoms that may indicate possible cancer. It's been shown to improve referral quality and reduce the number of times patients consult with GPs before they get their urgent cancer referral. We've fortunately been recently awarded funding for the first year of use of this, and its rollout is now underway. Elaine Lancaster from the Community Education Provider Network presented the expansion of physicians associates in primary care. There's a mandate from Health Education England to achieve a target of 1,000 PAs in primary care by 2020, with this number further increasing over the next 5 years. She presented the training requirements and what is being done to increase the numbers of applicants and how we can increase training within primary care. And finally, Doreen Redwood, the lead commissioner for Children's Services, presented the outcome of the September CQC inspection of the SEND service, which was as it was presented at the last governing body meeting. And that's all. Thank you.
That's great. Any comments or questions for Atin on the Council Members' report? Liz.
Yes, it's just in relation to the physicians' associates. I wondered how many we currently have in Kingston, and I also wondered what their regulation is, their professional regulation.
Sorry, I'm afraid I don't know the numbers on that. Can anyone help me on that one?
Yeah, they're going to be small numbers. And what we can do is get the actual numbers out to you, Liz. As regards to the regulation body, I think there's still some discussion around the regulation body on physicians associates. But again, we'll look into that and we'll get back to you on that if that's okay. Thank you. Any other comments or questions for Atin? Okay. So this is just for information. So thanks, Atin. Thanks for the detail on that. Can we come to the long-term plan? So Tonya.
Have I got it right? Thank you. Members will recall that actually the NHS long-term plan was published at the beginning of January, and I think it was just before we met last time, so we didn't really have an opportunity at the meeting when we met in January to discuss the long-term plan. And I thought it would be useful just to give you a bit of a snapshot, though of course I know that you've all read the long-term plan. So actually this is none of this is new, and but I thought it would just be useful to just have it on the record, so to speak, that we've discussed some of the high-level messages. And I personally welcome the long-term plan because it starts to shift the focus away from what has traditionally been an NHS approach to hospitals, and actually starts talking about early intervention, prevention, with a focus on mental health, some of the learning disabilities that we haven't previously seen in plans. So so I'm not going to go through all of it because it's there in your pack, but just some of the high-level messages. There is a real focus on prevention and reducing health inequalities. There will be new clinical standards built on the success of stroke and the cardiac networks. There was going to be reforms to hospital emergency care. So every hospital with a type 1A and E department will move to same-day emergency care model, and hospitals will establish acute frailty services. The rollout of NHS personalised care model across the country, and personalised care has 6 planks, but people would probably recognise that as more like social prescribing, personal health budgets and choice, and it's also about proactive care planning. So the rollout of that through across the country, and a boost of out-of-hospital care. And I must say that actually some of the changes in the long-term plan have hit the ground running, so we've already had published the guidance around the new contract, particularly around the establishment of primary care networks. So some of this work has already started. And just some of the other high-level messages, some of this connects to some of the conversation we've already had today. So there's a renewed commitment that mental health investment will grow faster than the overall NHS budget, and I think Neil, you said that we're making the mental health investment standard in our plans for this year. There's a guaranteed NHS support to people living in care homes, greater recognition and support for carers, and the integrated care systems to be rolled out across the country by April 2021. And that was just one area I wanted a little bit more focus on. So there's a couple of slides in, sorry they're not numbered, where it does give you a bit more detail of what integrated care systems could potentially be about. I would say that the thinking around integrated care is still emerging, and we are planning, acting at the same time. But there is a move to create integrated care systems everywhere by April 2021. And the aim of the integrated care systems is to deliver triple integration, and that means the integration of primary specialist care, the integration of physical and mental health services, and the integration of health and social care. So they are the prime objectives around integrated care. A key role in that then will be working with local authorities at a place level, and for to take away some doubt, place means in this context the borough. So we're working on place meaning the borough in South West London, and that's how we're starting to plan our services. And again, I think something that's pertinent to the conversations Sarah and James had around the finances, neither Trust nor CCGs will pursue actions which, whilst potentially improving their institutional financial positions, would result in a worse position for the system overall. So how I like to phrase it, failure for one is a failure for all, and achievement for one is an achievement for all. So I think that's how we want to move. So there's a new duty to collaborate for providers and CCGs. The only other points I wanted to raise today with members was the next steps in implementing the plan. So it's a 10-year plan. And we need to remember that. I'm sure it will outsee me, and I'm sure it will outsee a few others around this table, but it is a 10-year plan. We are being asked as a system, as a South West London system, to send our response to how we're going to deliver the first 5 years of the plan in the autumn. And of course, key to that will our local response, which is our local health and care plans. So you can see how the sort of jigsaw is fitting together. So our local health and care plans, which Julia and Iona and others have been leading. We had a very successful workshop yesterday where we started to really hone down the priorities and our deliverables in the health and care plan. So that is a really important. Some of you would have been involved in the event that we had in November. So that will start to articulate very clearly what we plan to deliver, aligned to both the long-term plan priorities and the health and wellbeing board priorities. You'd be unsurprised to see they're not dissimilar, that actually what we will be doing in the next 2 years. So I think that's really good. So it's all sort of coalescing together. The other thing will be that we will have a workforce implementation plan published later in 2019. I also think we have to respond to the health inequality aspect as well, don't we? We have to say what we're going to do to address health inequalities. So that's all I wanted to say about the long-term plan. I think there'll be lots of opportunities to discuss, debate, reflect, consider over the coming months, but I just thought it would be useful for the members to have a very quick snapshot. But I'm happy to take any questions.
That's a very helpful summary of 133 pages, so thank you, Tonya. Any comments or questions for Tonya on the long-term plan? I think we've seen various aspects of this over the course of the last 6 weeks or so. So thanks again, Tonya. So can we come to Board Assurance Framework, Vicky?
Thank you. So this report provides an overview of the risk controls, assurances and actions currently identified on our risk register and our board assurance framework. We have one very high risk identified for the CCG, which is around failure to meet some of the national performance targets. South West London CCGs recently undertook an internal audit towards the end of last year, and that was to provide assurance on the maintenance of an effective risk management system and board assurance framework. We received a rating of reasonable assurance for our risk management systems. One of the findings highlighted that there was a different approach with the other South West London CCGs in terms of which risks were pulled forward into the board assurance framework. So the other CCGs use a minimum risk score of 15, whereas we've used a minimum risk score of 9, and so the recommendation is that we manage things in the same way as the other CCGs. One of the decisions today is to seek your approval for doing that. There are 27 risks on the risk register, and there's a summary of risks attached to the paper. So we bring it to you to note the content and to take any questions or concerns you may have over the current levels of controls in place.
Okay, thank you very much. Thanks, Vicky. Comments or questions from board members around the assurance framework? No? Members of the public? No? Okay, so we're asking to note this, but also asking to approve the board assurance framework going from a minimum risk of 9 up to 15 to align ourselves with other CCGs, so we can actually get a good peer-to-peer view on this. Are we happy to approve this? Yes? Okay, thank you. Thank you, Vicky. So if we can come to minutes from the previous subcommittees. So is there anything that you want to go through further as regards to the Finance Subcommittee? Neil?
No, the bulk of the discussion at the Finance Committee was reviewing those 2 reports which we already looked at in a previous item.
Okay. Thank you. Integrated Quality and Governance Committee, Phil?
Nothing to add.
Thank you. Primary Care Commissioning Committee, Jim?
Nothing to add.
Thank you. Health and Wellbeing Board, happy to take questions, should you wish to give. Okay. Thank you. So there are recent policies that have been approved by the EMT. The first is around the primary care rebate scheme, and the second is around public sector equality duty. So any questions around those 2 policies that have been approved? No? Okay, so we ratify that. And we've got a reference document here which shows the glossary of terms, so that's just for information. Now, as regards any questions from the public not pertaining to items on the agenda that you want to bring forward? No? Thank you very much. So the next meeting will be on Tuesday, 7th of May, 3 to 5 here at the Fraser Chapel. And if we can just take a 5-minute break for the part 2, and then we'll take the part through to the other room. Okay? Thank you very much. Thank you very much for attending.